first half of the ostomy and continent diversion module, we focused on management of standard diversions, management of colostomy, ileostomy, urinary diversions. In the next few videotape lectures, we are going to focus on management of continent diversions. We're going to talk about the evolution of ostomy surgery, and then we're going to talk about two major groups of continent diversions. The abdominal reservoirs that involve catheterization to drain the reservoir, and the pelvic reservoirs that are managed by the patient's own sphincter mechanism. So in looking at the evolution of fecal diversions, we're going to talk first about fecal diversions, and then we'll cycle around and talk about urinary diversions. But you're going to hear very much the same thing in this session and in the session on continent urinary diversions. As we said, originally diversions were standard. We attached the bowel to the abdominal wall. There was no continence mechanism. Management was totally dependent on obtaining a secure pouching system. And that's still what's done for many patients today, so our pouching skills are still very much in demand. But in this class, we're going to focus on abdominal reservoirs and pelvic reservoirs. The concept of an abdominal reservoir is very simple. Instead of connecting the bowel directly to the abdominal wall and having the output, the stool, drain into an external pouch, the surgeon creates an internal pouch. That internal pouch is connected to the abdominal wall via a stoma. Between the stoma and the reservoir, the surgeon creates a continence mechanism, essentially a one-way path or a one-way valve. That one-way valve holds the stool in the reservoir until the patient passes a catheter through that one-way valve or that one-way path to drain the reservoir. So you have an internal reservoir connected to an abdominal stoma. Between the stoma and the reservoir, you have a continence mechanism, and management involves periodic catheterization to drain the contents. The most recent advance in ostomy surgery is the development of pelvic reservoirs. Many of you know these as J pouches. The concept of a pelvic reservoir is create an internal reservoir. Do not connect it to the abdominal wall. Instead, connect it to the patient's own anal canal. That allows the patient to control stool elimination by their own sphincter mechanism. So you see it's an evolution. We started out with standard diversions, connect the bowel directly to the abdominal wall, collect contents in an external pouch. Then the next step was create an internal reservoir, still connected to the abdominal wall, continence mechanism between the reservoir and the abdominal wall, pass a catheter periodically to drain the contents. And finally, the concept of an internal reservoir connected directly to the patient's own anal canal with evacuation controlled by the anal sphincters. Now we're going to talk about specific diversions. We're going to start out by talking about the abdominal reservoirs. Now let me just tell you that many of you will never see a patient who has had this procedure done, because today patients are much more likely to have pelvic reservoirs constructed as opposed to abdominal reservoirs. The abdominal reservoirs, specifically the Koch pouch and the Barnett continent ileal reservoir, are done only in specialized centers. There's about 3 in the United States. So the probability is you don't work at any of those 3 centers and you're not going to see many of these patients. However, patients travel from all over the country to go to one of those centers and then they go home. And so a patient might very well show up in your emergency room with one of these procedures, and you need to know the basics. That's what I want you to focus on, simply the basics, not the details. If you do start to work in a center where they do these procedures, you will of course sit down with the surgeon, find out exactly how he or she is doing the procedure. You'll go observe in the operating room. But at this point in time, I want you to understand the concepts behind these diversions. I want you to understand the basics of early management and late management. And then I want you to be prepared to look it up if you should ever have a patient who needs your assistance. So let's start with the Koch continent ileal reservoir. This was developed by Dr. Niels Koch, a Swedish surgeon back in the 60s. He was the first one to really think that instead of just improving external pouching systems, we should look at creating an internal reservoir and connecting it to the abdominal wall. So here's his concept. Create an internal reservoir out of loops of bowel, connect it to the abdominal wall, create a stoma, create a continence mechanism between the two, allow stool to drain into the reservoir, and then have the patient periodically pass a catheter to drain the contents out. He made this entire reservoir and the continence mechanism and the stoma out of the terminal ileum. And altogether it takes about 40 to 45 centimeters of terminal ileum. So then you go back to our discussion about the anatomy and physiology of the GI tract. You think about the fact that the last 100 centimeters of the ileum is the only site for absorption of vitamin B12 intrinsic factor complex. And you realize that these patients could potentially be at risk for B12 deficiency. So these patients are monitored, their B12 levels are monitored, so that should they develop deficiency, we can begin to supplement. Now, this is the most recent version of the abdominal reservoir. This is known as the BCIR, or Barnett Continent Ileal Reservoir. Dr. Barnett modified the original design slightly. He actually created a living collar, that's what he called it. He took an extra little piece of ileum, wrapped it around the continence mechanism, left one end open to the reservoir and the other end closed. You don't need to know any of the specifics. Basically, the way the living collar works is as the reservoir fills, this little loop of bowel fills, and it gives extra compression and extra support to the continence mechanism. Then when you pass the catheter and drain the reservoir, that little segment drains as well. Don't worry about any of the details. Get the big concept: formation of an internal reservoir, abdominal stoma, continence mechanism in between. Now, I do want to go through with you how they do this. I think it'll help you understand the basics. When I'm explaining it to a patient, I tell them, you know, it's very much like if you were throwing away an old shirt, long sleeve shirt, long sleeve blouse. You really liked the material and you wanted to make a scarf or something else out of it. You could take the sleeves, those long sleeves, you could open up the seams, and you could turn that tubular structure into a flat piece of material. And then you could reconfigure that piece of material into any shape you wanted. Well, look what they do here. They line up two limbs of bowel side by side. They open the front walls of the bowel. They suture the back walls. So you see how you've gone from two tubular structures to a flat piece. Then they create a continence mechanism between the stoma and the reservoir. We'll talk more about that. Once they've done that, they fold the bowel down on itself so it becomes now a pouch, a closed pouch. So now stool drains into the reservoir and is trapped there until we pass the catheter and drain the stool out. Now let's talk a little bit about the continence mechanism. The way Dr. Koch constructed the continence mechanism was to create an intussusception between the stoma and the reservoir. So I'm going to try to demonstrate this. I don't know how well it's going to do on video, but I'm going to try. So let's say, I'm going to come here. Let's say this is your reservoir, and this is going to be your stoma. So the surgeon comes in and literally intussuscepts the bowel between the stoma and the reservoir. Pulls that segment of bowel back on itself. So that inside the reservoir, you have a structure that looks like this. Now think about the fact the ileum is only an inch in diameter and it's muscular. So if you pull a 1 inch structure back on itself, it's going to collapse down and it's going to look like this. It's not going to be an open path. Remember also that in opening up the loops of bowel, you interrupt the muscle fibers, and so this is a non-contractile reservoir. So when they fold the bowel over to create the pouch, it's a non-contractile pouch. It just sits and stores. You have your stoma, and in between you have your intussusception, a very tight sleeve. So is the stool going to drain out through here? No. But let me get my catheter. When I pass the catheter, using a very gentle twisting motion, I want you to see that it's going to come through the continence mechanism into the reservoir and drain the stool out. When I pull it out, that intussusception collapses on itself. That's the basic concept. So here you see them creating the intussusception. Here is a picture intraoperatively of them creating the intussusception. This is going to be the reservoir, and you see it's going to be a relatively small reservoir at the outset, but it will stretch. So we talked already about that Dr. Barnett made improvements to the original design, primarily the living collar. He did that to improve continence and reduce the likelihood that additional surgery would be required to restore continence. You do not need to know specifics about the Barnett continent ileal reservoir. I want you to basically think of these procedures as being comparable because they are. They both involve creation of a non-contractile reservoir made out of ileum. They both involve formation of an abdominal stoma. Between the stoma and the reservoir, you have a continence mechanism. With the coat pouch, it's simply intussusception. With the Barnett continent ileal reservoir, it's intussusception plus that little living collar. Okay, so who's a candidate? When would you see a patient who might be contemplating a continent ileostomy or who might have a continent ileostomy? Well, go back to it's a continent ileostomy. So it's an alternative to the standard ileostomy. It's not an alternative to colostomy. It is an alternative to a standard ileostomy. So go back to what you learned about indications for an ileostomy in an adult. Well, one indication was to protect colonic anastomosis. And of course, you're not going to do all of this instead of a temporary ileostomy. But think about the indications for permanent ileostomy. What about a patient with ulcerative colitis where you need to remove the entire colon and rectum? They could have either a standard ileostomy or they could have a continent ileostomy. So the patient with ulcerative colitis would be a candidate. What about the patient with familial adenomatous polyposis? You need to remove the entire colon and the rectum. Small bowel is not involved. That patient would be a good candidate. So both the patient with ulcerative colitis and the patient with familial polyposis are good candidates for a continent ileostomy because they have a disease process involving the entire colon and rectum, but there is no small bowel involvement. The small bowel is healthy and can be used to create the reservoir. What about a patient with Crohn's disease? No, they in general are not good candidates because, as you know, Crohn's disease can involve any segment of the large intestine or small bowel. So if we took out the colon, took out the rectum, did a continent ileostomy, the risk is that the Crohn's disease could recur in the reservoir, and then we would end up taking out a fairly significant section of bowel in order to remove the segment involved with the flare-up of the Crohn's disease. Go back to the fact that with Crohn's disease patients, you're always trying to minimize the amount of bowel that's removed because you want to prevent short bowel long term. So in general, patients with Crohn's disease are considered not to be good candidates for a continent ileostomy. The one exception to this rule is a patient who has had Crohn's colitis, but no small bowel involvement. And they've been stable for a number of years, no small bowel involvement for a number of years. In that case, many surgeons will go ahead, they will do a continent ileostomy, but they will make sure up front that the patient is aware that they have a higher risk for pouch failure due to recurrence of the Crohn's disease. Now, what about a patient who some years ago, maybe 10, 15, 20 years ago, had a total colectomy, removal of the rectum, the anal canal, and the sphincters for either ulcerative colitis or familial polyposis. So essentially they had a proctocolectomy. They have no anal canal and no sphincters. They have an end ileostomy. Could they have a continent ileostomy? Absolutely, because their small bowel remains healthy and intact. So you could go in, disconnect the ileum from the abdominal wall, create the reservoir, then reattach the bowel to the abdominal wall, create the intussusception in between. So yes, a patient who in the past has had a proctocolectomy for not for Crohn's disease, patient who's had a proctocolectomy for ulcerative colitis or for familial polyposis who now wishes to have a continent procedure is indeed a candidate for Koch pouch or Barnett continent ileal reservoir. We have had those patients. I remember one patient we had, she had had her ileostomy for about 15 years at the time that she had a conversion to a continent ileostomy. She actually was doing well, but she had recurrent problems with peristomal skin breakdown. She had had to have 2 stoma revisions, and she was only in her 30s. So when she read about the continent ileostomy, she came to us and she said, could I have this done? She had had her entire colon, rectum, anal canal, and sphincters removed, but her small bowel was totally healthy. She had ulcerative colitis. Yes, she was an excellent candidate. She did undergo continent ileostomy, and she was very, very pleased with the results. So that brings us to the last thing. The patient has to be motivated and reliable. They have to be motivated because they are going to go through an extensive surgical procedure. They have to learn how to pass the catheter. They have to be willing to self-catheterize their reservoir several times a day for the rest of their lives. So yes, we need patients who understand what's going to be done, who want this done, who want to have an internal reservoir, and who are willing to do the catheterization. So pre-op teaching. You already know that pre-op teaching comes down to 2 major things. Make sure that the patient understands the procedure that's going to be done and what that means to him or her in terms of stool elimination. And then determine the patient's concerns and questions and focus your discussion on those issues. So specifically for the patient who's thinking about having a continent ileostomy, we want to focus on the fact that they will have an internal reservoir, that there will be a continence mechanism between the reservoir and the abdominal wall that will trap the stool in the reservoir. That in order to remove the stool and eliminate the stool, they must pass the catheter into the reservoir, that this has to be done several times a day for the rest of their lives. They have to be careful, they have to be comfortable with that. Now, a common question is, will it hurt? No, you go back to the fact that the bowel is essentially insensate, the stoma is insensate, so no, it's not painful, but it has to be done. It has to be done routinely, so they have to understand that. Now, the second thing is also very important. I was at a conference held by Palms of Pasadena Hospital in Florida. That's one of the centers where they do these procedures. And they emphasized the point that well over half of the patients who undergo this procedure will require additional surgical procedures to maintain continence. And they said they present it to their patients in this manner. They explained that the initial procedure is almost like a down payment, and that periodically they will probably need additional minor procedures done to maintain normal function, to maintain continence. So the patient has to realize that there is no guarantee that this one procedure will keep them continent for the rest of their lives. They have to be willing to maintain follow-up. They have to know up front that they could require additional surgical procedures, and that in fact most people do. And then they need to understand advantages and disadvantages. What are the pros, what are the cons? So what are they? Well, the advantages are pretty clear-cut. When you compare a continent ileostomy to a standard ileostomy, one advantage is you don't have to wear a pouch. And you don't have all of the issues with maintaining a secure pouch seal, potential for skin breakdown, those kinds of things. Much easier to conceal the stoma, because the stoma with a continent ileostomy is flat to the skin, and they just wear a very flat cover over the stoma. And they essentially have modified continence. So they have output when they put the catheter in, but the rest of the time the stool is retained within the reservoir. So are there any negatives? Anytime we have to revise our natural plumbing system, there are always some negatives. So here are the negatives. Actually, I'm going to go past this. We already talked about that. First of all, they will have a stoma. So there's still a visible reminder that they had surgery, and they will have to wear a covering over the stoma. So it's not like there's nothing there. Secondly, they will have to carry a catheter with them at all times, and they may very well have to drain the reservoir in a public restroom. And patients who have had this procedure done tell us that one of the most difficult aspects of having the procedure done is the fact that when they have to drain in a public restroom, there's noise, because when they pass the catheter in, all the gas explodes through the catheter, so that it can be very noisy, and that there's odor associated with draining in a public restroom. Of course, they can use a room spray, and that's going to help tremendously, but still, they're very aware of that. So you want to be honest with your patients. You want to let them know what the potential issues are. Likelihood of additional surgical procedures we talked about. And there are some dietary modifications. You think about the fact that everything has to drain through this catheter. So in general, they need to avoid peels. They have to be very careful of foods that are high in insoluble fiber. So if they eat nuts or they eat stringy vegetables, they have to chew extremely well, and they have to limit quantity. Most of them find which foods they do well with, which foods drain well through the catheter, and which foods they need to avoid or strictly limit. So there are some modifications, there are some limitations associated with this. But look at the outcomes. 80 to 90% of patients who have this procedure done still retain the reservoir at 10 years. 75 to 80% still retain the reservoir at 20 years. You don't have to know that. It's not in your handout. I just wanted you to get the sense that even though there are some negatives, even though there are some adjustments, most patients do very well. And that's the bottom line. When we ask patients about their satisfaction with their continent ileostomy, their satisfaction level is usually very high. I've had patients come in who are having complications, and what they most want to hear is that we're not going to take their pouch away. So, in general, outcomes are good. So now we're going to talk about management, and we're going to break management down into the early post-op phase and then long-term. Now think about what we've done. And I put this picture in here because I want you to have a concept of what it looks like post-operatively if you really see the reservoir. So you've got this relatively small reservoir, and you see how you have all of these suture lines? These suture lines have to heal. We do not want the reservoir to distend prematurely. If the reservoir begins to distend before those suture lines have healed, you can get anastomotic breakdown and peritonitis. So goal number one, keep the reservoir decompressed for the first 2 to 3 weeks until healing is complete. Now think about the fact that we have just created this intussusception. So we've doubled the bowel back on itself, and then we've sutured or stapled the intussuscepted walls together. But that intussusception has to heal as well. In order to keep the reservoir decompressed, we either have to put the catheter in and out very frequently, like every hour, or we have to put a catheter in and leave it in. But when you think about that newly created intussusception, you don't want to put a catheter in and out, in and out, in and out, because you're causing a lot of trauma to that newly created continence mechanism. So what you'll see them doing is they will place the reservoir catheter at the time of surgery, and the patient will come back from surgery with the reservoir catheter in place and connected to gravity drainage. Having the reservoir catheter in place and connected to gravity drainage meets both of those goals. It prevents in and out catheterization and the related trauma, so it protects the intussusception while it heals. It keeps the reservoir decompressed while it heals. So they come back from surgery with a reservoir catheter in place, either to gravity drainage or to wall suction. What do we need to teach our nursing staff if we're ever in a situation where they're doing these procedures? The critical thing is to irrigate this catheter, usually about every 2 hours in PRN, to keep it patent, because there's going to be thick mucousy drainage coming through this, a little bit of blood, and then once the patient starts eating, of course, the drainage will be even thicker. And these little eye holes in the suction catheter could easily become occluded. If they become occluded and the catheter stops draining, then the reservoir distends and you have to worry about an anastomotic breakdown. So, they come back with the catheter in place as you see. Catheter is connected to gravity drainage. We irrigate the catheter on a routine basis and PRN. Typically, we put the patient on a low-fiber diet to keep the stool from being so chunky, to keep it mushy so it will drain through the catheter. The catheter typically stays in about 2 to 3 weeks. At that time, usually the suture lines are well healed. The intussusception is well healed. At that point in time, you're going to remove the reservoir catheter, and we're going to teach the patient in and out catheterization. Now think about the fact that you've had this intussusception propped open for 2 to 3 weeks with a fairly large bore catheter. Usually they have about a 30 to 32 French catheter in place. So when they take this out, it takes a little while before those walls tighten up. It's a muscular sleeve, it will tighten up. But it's pretty common for the patient to have some leakage for the first 2 to 3 days following removal of the reservoir catheter. Pretty important for us to tell the patient to expect the possibility of some leakage. Otherwise, think how upset you would be if you had gone through this entire procedure, you put up with having this catheter in for 2 to 3 weeks, and then as soon as the catheter comes out, you start leaking stool. You'd be distraught because you'd be convinced that the procedure didn't work and you weren't going to be kind. Critical to tell the patient, expect leakage. Expect leakage for 5 to 7 days. In reality, it's typically only 2 to 3, but I always give them that outside limit. Okay, so early post-op, it's all about letting the reservoir heal, all those suture lines, letting the continence mechanism heal, keeping that reservoir catheter in, and keeping it patent. Now we're to phase 2. We've pulled out the reservoir catheter. At baseline, the reservoir is pretty small. Typically, the reservoir holds about 50 to 75 cc's at baseline. Go back 1, can see this is a pretty small reservoir. It's not going to hold a lot. Think about the fact that average output from an ileostomy, even after the first 2 weeks, is somewhere between 500 cc's and 1,000 cc's a day. And the baby reservoir holds 50 to 75. So that tells you that initially the patient will need to self-catheterize pretty often. Most surgeons put their patients on a Q1 to 2 hour catheterization schedule during the day and Q2 to 3 at night for the first week when they're doing in and out catheterization. Now at this point, the reservoir has healed, and it's okay for that reservoir to begin to stretch. So we want to stretch it a little bit at a time. We don't want to overstretch it at any one time. So let's say we pull the reservoir catheter, bring the patient into the office, pull the reservoir catheter at 8 a.m. Teach the patient how to do in and out catheterization. We're going to send them home with a schedule. They're going to be catheterizing at 10 o'clock, at 12 o'clock, at 2 o'clock, at 4 o'clock, at 6 o'clock, at 8 o'clock, at 10 o'clock, at 12 o'clock, at 3 a.m., at 6 a.m. for the first week. The second week, they extend the interval. Third week, they extend again. Long term, the intervals are 3 to 4 hours and PRN. So I might drain my reservoir when I first get up in the morning around 7. I might not drain it again until about 11. And then I'll probably drain it mid-afternoon, and then I'll drain it early evening and at bedtime. As time goes on, these reservoirs frequently expand to hold somewhere between 300 and 500 cc's. So long-term, some patients are able to catheterize even less frequently, every 4 to 6 hours. But up front, what I tell them, be prepared to catheterize every 3 to 4 hours and as needed. Well, how would you know it was needed? You feel full. Your reservoir feels full. And even if it's not time to catheterize, when your reservoir feels full, either you have a little bit of diarrhea or you have a lot of gas in that reservoir. So you've got to go past the catheter, remove the gas, eliminate the liquid stool. Now, in teaching them to catheterize, we're going to give them a large bore catheter. A narrow catheter will not drain thick ileal secretion. So you have to have a large bore catheter. This one's a 34 French. It's a Marlin 34 French, one that's very widely used. As I showed you, as we show the patient, you're going to pass the catheter, you're going to use steady pressure, you're going to use this twirling back and forth motion so that you feel your way through the continence mechanism. You never force the catheter. You tell the patient, never ever force the catheter. And I'm going to show you why. If you force the catheter, you could end up going right through this intussusception and creating a fistula. And then they would lose continence. So critical to tell them. You've got to be careful with your continence mechanism. You want this continence mechanism to last you as long as possible. Because when the continence mechanism fails, you have to go back to surgery. How do you protect your continence mechanism? First of all, don't let your pouch overfill. If you're starting to feel full, go drain your pouch, because as the pouch gets fuller and fuller, it creates more and more compression of this intussusception, and then it's like catheterizing through a brick wall. That's almost impossible. So don't let your reservoir overfill. Lubricate your catheter, steady pressure, twisting motion. One of the common issues is, what if I can't get the catheter in? We got calls, I can't get my catheter in. I'm scared to death. I can't get the catheter in. I've been trying for 15 minutes. So we learn to teach our patients strategies for what to do if you're having trouble passing the catheter. Goes back to, why would you have trouble passing the catheter in the first place? Well, here are some common reasons. Overfilling of the reservoir, like I just explained. If I'm very tense and my abdominal muscles are tense, my abdominal muscles surround the stoma and the continence mechanism, so I'm getting extra compressive force. A very common reason is slight swelling in the bowel wall, so maybe a very, very mild gastroenteritis, a little bit of increase in stool production, a little bit of swelling of the bowel wall, and now you've got a very tight sleeve. And sometimes it's the angle of the continence mechanism of the intussusception. What do we teach patients to do? How do we teach them to manage if they're having trouble with catheterization? And this will be a test question. Indications will be a test question. How to manage difficult intubation will be a test question. So first of all, don't delay. Intubate on schedule, intubate when you start to feel full. If you're starting to get tense, stop, put your catheter down, do some deep breathing exercises to relax your abdominal wall before you try again. Now let me point out the strategies that are most likely to be beneficial. Smaller catheter, different position. Smaller catheter because remember that a common reason for difficulty in passing this large catheter is a little bit of swelling in the passageway. So if I can't get a 34 in, can I get a 26? Almost always the answer is yes. That is the strategy that is most likely to be effective. Put in a smaller catheter. And most agencies send their patients home with their standard catheter and an emergency catheter that is 8 French sizes smaller, so 26 instead of 34. Finally, remember that sometimes it's the angle of the continence mechanism that's making it very hard to pass the catheter. So if you've been trying sitting down, try lying down, try standing up, try leaning forward. So these are the strategies that are most likely to be effective. Now sometimes patients have trouble draining the reservoir because the stool has gotten so thick. They're like, it's taking me forever to drain the reservoir, what can I do? Well, here are the things they can do. Increase their fluid intake so that their stool's not so thick. If they have the catheter in they have the catheter in and nothing wants to drain out, they can take a syringe with lukewarm water and they can push lukewarm water into the reservoir to thin out the stool so that it will then drain through the reservoir catheter. A lot of patients do that, and it's very easy to do at home because you can have a cup of water and a syringe right there in your bathroom. Obviously much harder to do when you're out in a public restroom. Third thing, you're going to have more problems if you've been eating a lot of insoluble fiber and your stool's really thick, so limit your insoluble fiber, chew your food really well so that you don't have big chunks that are trying to drain through. But for patients who have thick stool on an ongoing basis, one of the things that can be very helpful that I actually learned from a physician at one of the continent reservoir centers, Palms of Pasadena, is put that patient on a daily dose of Miralax so that they're pulling more fluid into the GI tract. They're maintaining a more fluid stool that drains more readily through the catheter. Here's another problem that can occur. This is probably the most distressing long-term complication. The two most distressing long-term complications. Failure of the continence mechanism and repeat leakage. That's obviously very distressing because it means they have to go back to surgery. The other thing is pouchitis. And pouchitis is just what it sounds like. It's inflammation of the reservoir. I remember the first patient we had to have pouchitis, she showed up in the emergency room because she put her catheter in and all she got out was blood. And when they scoped past the pediatric scope and looked at her reservoir, the entire lining was totally inflamed and oozing blood. Now, what we don't truly understand is what causes pouchitis. Certainly we understand that we've taken a tubular structure that's designed to move stool along and we've turned it into a holding area so that we have changed the natural environment. The most common theories about pouchitis is that it has to do with the bacteria in the reservoir. That either we've got an overgrowth of bacteria, that we've got a change in the balance of bacteria so that the balance between aerobes and anaerobes is altered, the balance between good bacteria and bad bacteria is altered. We realize that having fecal stasis can in and of itself cause some ischemic insult to the mucosal layer of the bowel wall. Finally, there's some evidence that within the reservoir you might have low levels of short-chain fatty acids, and it's short-chain fatty acids that keep the cells of the bowel wall healthy. All of this tends to go back to bacterial overgrowth. We'll come back to that in a minute. So what is it? Inflammation. How does the patient know they have pouchitis? You go back to an inflammatory process. So first of all, the reservoir feels tender and itchy. Patients will tell you, I can draw a line around my reservoir and I want to scratch it out. And at the same time, it's sore. So itchiness, soreness, cramping pain when they eat. So I've had patients tell me, I don't want to eat because every time I eat, I have cramping pain. They feel bad in general. Sometimes they run a low-grade temp. They feel full at low volumes. So back to the theories regarding cause. Fecal stasis, bacterial overgrowth. Bacteria compete for oxygen and nutrients and can damage the cells in the bowel wall. Change in the balance between aerobes and anaerobes, good bacteria, bad bacteria, and reduced amounts of short-chain fatty acids. Pouchitis is a very difficult complication. It makes people feel bad. We know how to treat it, but it keeps coming back. So obviously what we want to do is prevent it. But it's hard to prevent pouchitis because we don't truly understand what causes it. So let me tell you some of the things that have been tried and tell you what the current thinking is. Early on, we taught patients to irrigate their reservoir till clear twice a day. So put in the catheter, drain out all the stool, then put in clear water, drain, drain until the returns were coming back essentially clear. And our thinking was that we would flush out any residual stool, we would flush out a lot of the bacteria, and would prevent fecal stasis and bacterial overgrowth. Now that's very controversial because we've learned so much more about bowel health. And we've realized, or we have learned, that when you're constantly flushing a segment of the bowel, you're altering the bacterial balance and you're flushing out the good bacteria and you might be causing the problem. So at present, the concept of routine irrigation is very controversial and most clinicians are moving away from that recommendation. But what about probiotics and dietary fiber? That is gaining increasing support. Probiotics are good bacteria like lactobacilli, bifidobacterium. They interact with the fiber in the diet, soluble fiber, as well as insoluble fiber, to produce protective compounds, symbiotics that actually protect the bowel wall. And there's increasing evidence that routine use of probiotics, routine intake of probiotics can help prevent pouchitis and can help prevent recurrence in a patient who's had one episode. So routine irrigation of the reservoir, I talked about the theoretical benefit. I've told you there's a lot of questions about that at present, and most clinicians are moving away from those recommendations. So I was on a very interesting panel with other clinicians, and patients had the opportunity to pose questions. And so one of the patients asked, should I be irrigating my reservoir, my Coke pouch? And basically what the panel concluded was this: we don't know. So we said to that patient, are you irrigating at present? And she said yes. And we said, are you doing well? And she said yes. And we said, keep irrigating. And another patient said, I'm not irrigating. Should I start? And we said, are you doing well? And the patient said yes. And we said, don't start. So if you're irrigating and it's working, keep irrigating. If you're not irrigating and your pouch is healthy, don't start. If you are irrigating and you're having frequent episodes of pouchitis, try not irrigating. Again, we don't know. We need studies, we need data. So at this point, I just want you to know that it's very controversial. Probiotics, I think you know a lot about them. They're the good bacteria, Lactobacillus GG, Bifidobacterium, Saccharomyces. Those are some of the most commonly used. And we do have increasing levels of data that they can help prevent pouchitis or prevent recurrence. So if I was taking care of a patient today who had a continent ileostomy, I would automatically put that patient on probiotics. And in fact, when I've talked to patients on the phone who had continent ileostomies and who had had episodes of pouchitis, I have counseled them to begin probiotics and to do probiotics once or twice a day, every day. Now, what about a patient who has pouchitis? How do we treat it? Goes back to bacteria. We know that it's linked to bacteria. So how do we treat? With antibacterial compounds. So we usually start with either Flagyl or Cipro. Some clinicians start with one, some start with the other. If they fail one, you go to the other. So most start with Flagyl, and if they fail Flagyl, they go to Cipro. If they're refractory, if they continue to have symptoms, a lot of times they'll do anti-inflammatory agents, sometimes directly into the reservoir, sometimes systemically, and again, probiotics. Now, managing the peristomal skin, remember that this stoma is going to produce mucus, so they do need to wear a protective absorptive cover to manage the mucus and also to protect the stoma itself. There is a company, also medical products, that make a patch that fits over a continent diversion stoma, so you can peel it off, catheterize, and stick it back down. Some patients use that, but other patients just wear a mini pad and stick it to their underwear so that their underwear is protected, the stoma is protected, but when they go to catheterize, all they have to do is roll their underwear down. Either will work. Some patients are very sensitive to mucus and may benefit from routine use of a sealant. Other patients don't seem to need it. And of course, yes, they can get a yeast rash, and should that happen, we are going to end up treating them with an antifungal cream or an antifungal powder. Finally, these patients should have medic alert just in case something happens to them and they end up in the emergency room. People need to know that stoma has to be catheterized at intervals to drain the reservoir. Now, what about diet? They can eat most foods, but you go back to, and this is a good thing to say to the patient, everything has to come through this. So when you're at the salad bar, think about the fact that everything has to come through the catheter. So there are some modifications. Peels don't do well. You usually can't chew them up well enough, so no peels. Any foods that you cannot chew up well enough that they're going to drain through, you're going to need to strictly limit or avoid. If there are foods that you find cause you excessive gas or diarrhea, that's going to cause your reservoir to fill up much more quickly, so you probably want to think about how much of that you eat and when. But most foods they can eat. Medications goes back to what we tell all of our ileostomy patients. You've lost the colon and the very end of the small bowels, so don't take time release, don't take enteric-coated, don't take large tablets. Also, these patients should not take medications that are embedded in a wax matrix. Some of your sustained release medications are embedded in a wax matrix. And that wax shell will not pass through this catheter, and they'll just stack up in the reservoir. So, what are the advantages of this continent ileostomy? No external pouch, high rates of continence. Most patients are very well satisfied. What are the disadvantages? They do have to catheterize multiple times every day. It can be hard to drain when the stool is thick, and pouchitis is always a possibility. So now what we're going to do is we're going to move on to the most recent advance in development of fecal diversions, and you definitely need to understand these options because most of you will have patients who have had this done. Most of you will either now or in the future work with surgeons who are performing this procedure. So now we're going to move from abdominal reservoirs to pelvic reservoirs. And I put these slides side by side so that you could appreciate the difference. With the abdominal reservoir, you have a stoma, you have a continence mechanism between the stoma and the reservoir. Management involves repetitive catheterization. With the pelvic reservoir, you create that non-contractile reservoir. The surgeon creates the non-contractile reservoir. But look what you've done. You've connected it to the patient's own anal canal. So output is controlled by the patient's own sphincter mechanism. So you create an internal pouch, you connect it to the anal canal. Sounds perfect, doesn't it? It sounds just like normal, just like you had before surgery. Except, remember that you've removed the colon, and the colon's responsible for reabsorption of water from the stool and for conversion of liquid stool to solid stool. So you're going to have large volume enzymatic stool draining into this reservoir, and it's going to be your sphincters that maintain continence and that protect your skin. So it's much like having chronic diarrhea, especially at first. So large volume enzymatic output. Clearly, good sphincter tone is essential. You have to have strong sphincters. And even with good sphincter tone, early post-op, you're going to have issues with fecal urgency, with frequency, and with the potential for leakage. That's going to continue throughout life if you have an episode of gastroenteritis. So they have to know it's not like before. Your colon is missing, and your colon did some important work. But there are certainly major advantages in that you don't have an external stoma and you don't have to pass a catheter. So if you have strong sphincters, this is a very realistic alternative. So this is known as ileal pouch. So you create the pouch out of the ileum. Anal anastomosis, IPAA. So here's your pouch connected to the anal canal. Looking at what's done, the colon and most of the rectum are removed because these procedures are done for patients who have ulcerative colitis or familial polyposis. Those are mucosal diseases affecting the rectum and the colon. They're going to remove the entire colon. They're going to remove the rectum down to about 1 centimeter above the anorectal junction. They want to protect the integrity of the sphincters, and the sphincters come in right at the anorectal junction. So they'll leave a very small cuff, about 1 centimeter of rectum, and they're going to connect or anastomose this reservoir to that rectal cuff. Now, one of the questions they frequently ask on the certification exam is about mucosal stripping. So think about the fact that you've got like a 1 centimeter cuff of rectum. That 1 centimeter cuff of rectum is lined with mucosa. Both familial polyposis and ulcerative colitis are mucosal diseases. So if you leave that 1 centimeter of rectum with that mucosal lining, there is the potential that the colitis could recur there or that you could develop polyps there. There are two schools of thought. Some surgeons will actually strip out the mucosa to eliminate any potential for recurrence. The positive is you eliminate any potential for recurrence. The negative is the additional manipulation right there just above the sphincter mechanism can cause increased problems with continence, especially early post-op. The other school of thought is you have a very minimal section of rectum that remains. And it's very easy to pass an endoscope and to inspect that little 1 centimeter cuff and to make sure there are no problems. If we leave the mucosa, we can monitor and we eliminate the risk of causing sphincter dysfunction. Pros and cons. Some surgeons do mucosal stripping, other surgeons do not. At this point in time, we don't have enough data to say that one way is right and the other is wrong. Advantages and disadvantages to each approach. You should just know why mucosal stripping might be done, and you should also know why some surgeons elect not to do it, because that might be a question on the certification exam. But you always take out the colon, you always take out most of the rectum down to that little cuff. You may or may not strip out the mucosa. Then you form a reservoir from loops of the ileum, and you connect the reservoir to that rectal cuff just above the anal sphincters. Now, the ileal pouch anal anastomosis procedure can be done as a one-stage procedure, can be done as a two-stage procedure, which is the most common, or can be done as a three-stage procedure. I'm going to describe each of them, but we are going to focus on the two-stage procedure because that's by far the most common. And essentially all of your test questions will relate to the two-stage procedure. So what's a one-stage? This reflects a one-stage procedure. The patient goes to surgery with an intact GI tract. The GI tract's not healthy, but it's intact. During surgery, the colon is removed. The rectum is removed down to that little cuff. The end of the ileum is used to create a reservoir. So those loops of bowel lined up, reconfigured to form a reservoir. The reservoir is connected to that rectal cuff, and the patient is sent to recovery. If you do a one-stage procedure, it means you have one operative procedure where you remove the colon, remove the rectum, create the reservoir, and connect the reservoir to the anal canal. The good thing about a one-stage procedure, you don't have to go back to surgery. The bad thing about a one-stage procedure is that the first few months post-op are totally miserable because the patient's dealing with very high volume output, and it all has to be controlled by their anal sphincter mechanism. So they have a pretty high risk for severe urgency, frequency, and bouts of incontinence during the first few months post-op. Two-stage procedure, by far the most common. This represents what's done in stage one. The colon's removed, the rectum's removed all the way down to that cuff. The reservoir is created. The reservoir is connected to the rectal cuff, but they do a temporary diverting ileostomy. So above the level of the reservoir, they create an ileostomy which protects the reservoir, allows the reservoir to heal, allows the patient to regain sphincter tone post-operatively. And then stage two is ileostomy takedown. So the ileostomy plays a protective role, protects the reservoir, allows healing to occur, gets the patient through that very high volume adaptation phase when they have very high volume output. Instead of running to the bathroom every few minutes, they're emptying their pouch every 1 to 2 hours. But of course, the negative is that they have an ileostomy for a period of time and that they require 2 surgical procedures instead of only 1. Three-stage procedure is not commonly done at all. When it is done, this is what it involves. In stage 1, they do a colectomy, they take out the colon, they do an ileostomy, and they do a Hartmann's pouch. So they leave the rectum, anal canal, sphincters intact. Stage 2, they disconnect the ileostomy from the abdominal wall. They remove most of the rectum down to that rectal cuff. They create the reservoir out of the distal ileum. They connect the reservoir to the rectal cuff, and they do a diverting ileostomy. And then stage 3 is ileostomy takedown. So basically what they do in stage 1 is just remove the acutely diseased colon, do the Hartmann's pouch so that everything's preserved, do the ileostomy, let the patient recover, bring the patient back, create the reservoir, connect the reservoir, do the protective ileostomy, bring the patient back again, and take down the ileostomy. Now, why would you do that? Here's 3 situations when you might do this. First of all, if you have a patient who is acutely ill at the time of the original surgery, maybe they've been bleeding heavily, they're on high-dose steroids, the patient's not very stable, they're trying to minimize the surgical procedure and surgical time, they just need to get in and out, but they want to give the patient the option for a continent diversion long-term, for a sphincter-sparing procedure long-term. Then they can do colectomy, Hartman's pouch, ileostomy, get the patient over that hump, over that crisis, with all of their options intact. Situation number 2, the patient gets into trouble, maybe they're in an area where there's not a major medical center. The surgery is done by a surgeon who's not experienced in ileopouch anal anastomosis procedures, but he certainly, or she certainly, can remove the colon, do the Hartman's pouch, do the ileostomy. Again, you get the patient over the crisis, over the hump, with all of their options intact. And the third situation, and this is when I've seen it the most commonly, is think about the fact that for patients with ulcerative colitis, up until the time of surgery, they're typically on high-dose steroids trying to get the inflammation under control. And you know how patients gain weight with steroids. And it's very, very hard for them to lose weight while they're on those steroids. Now, when you do this pelvic pouch procedure, I just want you to realize that you create this reservoir. This bowel is connected to the mesentery. You have to pull this reservoir and the mesentery way, way down into the pelvis, down to the anorectal junction, way out of its typical intra-abdominal position. That means you need a mesentery that is very mobile. And you know that with abdominal weight gain, the mesentery becomes less mobile. So sometimes you have a patient who wants to have an IPAA, but they're not candidates because we literally can't get the reservoir down into the pelvis until they lose weight. So in that situation, what we've done is we have done the 3-stage procedure. Taken out the colon, done the Hartman's pouch and the ileostomy. Once we get the colon out, we can start tapering down the steroids, give them a period of time to lose that weight so that the mesentery again becomes mobile. Then take them back to surgery, create the reservoir, connect the reservoir to the anal canal, do a protective ileostomy, and then bring them back and close it. I'm not going to ask you about the 3-stage procedure. The other thing that's in your handout is the types of reservoirs. I want you to focus on J reservoirs. J reservoir is the type most commonly done across the world because it's simple and it works well. So basically a J or a reverse J, you can see why it's named J or reverse J because it's in the shape of a J or a reverse J. So what they do is they bring the bowel down and around. This is closed. Okay, so now you have the bowel, you have 2 limbs of bowel. They create an opening here. They go up with a crushing clamp and they destroy the wall between these 2 limbs. Okay, so they cut through the wall and at the same time they're firing staples. Okay, so you end up with this being a reservoir. So they loop it back, anastomose it, open it. The good thing about the J reservoir, it sits right above the anal canal, so you have no problems with emptying. It empties effectively. The problem is it does sit right above the anal canal, so these patients sometimes have more problems with leakage early post-op. And as we've said, you need a very mobile mesentery. The S reservoir we will not ask you about. I'm going to explain it briefly. This was one of the first reservoirs done. They used 3 limbs of bowel, which is why they call it an S reservoir. It created a larger reservoir that sat a little bit higher in the pelvis, so you ended up with a longer spout. The disadvantage was it was harder to empty. Patients had to strain a lot to empty. Sometimes they had to pass a catheter into the reservoir to empty. That's why it's not commonly done. J reservoir is the procedure that you should focus on. And the UOAA, they have a group, a support group known as the J pouch group. That's because J pouches are by far the most common reservoir. One reason I wanted to mention the S reservoir is that sometimes they'll get in there and the mesentery is still not mobile enough to allow them to pull the bowel all the way down deep into the pelvis. The S reservoir sits a little bit higher and doesn't require as much stretch. So there might be occasions when a patient might have an S reservoir, but it would be rare. You would look it up. I'm not going to ask you about it. Okay, so now let's talk about indications and management. The indications are going to be very similar to what we talked about with the continent ileostomy. Patients who have ulcerative colitis are good candidates because their disease process is limited to the colon. And once you take out the colon and the rectum down to that little rectal cuff, you create the reservoir, bring it down to the rectal cuff. Essentially, you've eliminated the disease process and you expect this patient to be healthy with no recurrence. Same thing with familial polyposis. You need strong sphincters. So if you have a woman who has had obstetric trauma and she has problems with incontinence during episodes of diarrhea, she would not be a good candidate. So you have to have good sphincter function. Most surgeons send patients for anorectal studies to make absolutely sure that they have adequate sphincter function. They need to be slender for the reasons we've already talked about. You need a mobile mesentery. They need to be motivated because most of these patients are going to have a minimum of 2 surgical procedures. After the first surgical procedure, they're going to have to learn how to manage a high output ileostomy. After the second surgical procedure, they have to manage frequent episodes of diarrhea for the first few months. So this is not a good choice for people who want a quick fix. They need to understand what they're getting into. Crohn's disease, contraindicated for the same reasons we've already covered. Again, if you had a patient who had intact anal canal and sphincters, had no small bowel involvement for a number of years, then some surgeons would be willing to do the ileopouch anal anastomosis. One thing I should point out, and I didn't put it on the slide, but I probably should have. What if you have a patient who 20 years ago had a proctocolectomy, removed the colon, the rectum, the anal canal, the sphincters, and did a permanent ileostomy for ulcerative colitis. And then the patient comes and says, I read about those J pouches, could I have one? And of course the answer would be no, you can't have a J pouch because your anal canal and your sphincters are gone. And the whole concept of the pelvic reservoir is you create a reservoir, you anastomose that reservoir to the patient's anal canal. Stool output is controlled by their sphincters. So if you have had a previous proctocolectomy, you have an ileostomy, you're looking for a continent procedure, you would be a candidate for a coke pouch or BCIR. You would not be a candidate for a J pouch, the ileopouch anal anastomosis. If that doesn't make sense, give us a call because that's an important concept. Okay, so pre-op teaching again, you want them to understand the procedure to be done and the implications. So we're going to remove the colon. That means they're going to have higher volume stool, mushier stool. Major implications. If they're going to have a 2-stage procedure, they have to understand that after stage 1, they'll have an ileostomy, that they'll have that somewhere between 2 and 6 months typically. And that then they'll have to go back to surgery to have the ileostomy closed. They have to understand that even on a long-term basis, they're going to have more frequent bowel movements than the average person. Average stool frequency is about 4 to 6 stools a day, and for some patients it's higher. And if they get into a gastroenteritis, of course it's going to be higher. Anytime that they have a gastroenteritis, and for the first few months after surgery, they're going to have issues with fecal urgency, that sensation, I've got to go right now. They're going to have problems with frequency, and they will be at some risk for leakage. Now, there's a lot we can do to reduce that, but they just have to know what the issues are. So, for most people, at least 2 surgical procedures, period of time with a high output ileostomy, and then adaptation to a substitute rectum and absence of a colon, which translates into lifelong, more frequent stools, more problems with urgency, more risk for leakage. They have to know no anal intercourse, because you have connected the reservoir to the anal canal and you're going to get scar tissue right there. Anal intercourse would stretch the anastomotic line, it would stretch the scar tissue, it would create the risk for bleeding or for disruption. So no anal intercourse. We tell all of our patients that. And I have had patients who have changed their minds about which procedure they were going to have based on that information. So I don't want to wait and tell them about that post-op. That's too late. I need to tell them pre-op. Now, I know that feels weird to a lot of you because you're like, well, most of my patients wouldn't be having anal intercourse anyway. True, but you don't know who is and who isn't. So a good way to handle it is to say, I don't know if this applies to you or not, but we tell all of our patients this. And that is that following this procedure, anal intercourse is totally prohibited lifelong. So if that's a concern for you, we need to talk more about that and talk about your options. And then once you make sure they understand what's going to be done, then you cycle back around to determine what are their questions, what are their concerns, and that's what you focus on. So now let's talk about post-op management. If you have a one-stage procedure, remember I'm not going to ask you about this, but if you have a patient who has a one-stage procedure, everything's done at once. They go to surgery with a colon and a rectum, they come back with no colon, only a rectal cuff, a reservoir connected to the anal canal. Before that patient goes to surgery, I want them to be very clear that when they come back, they're going to have a tough few months because they're going to have urgency, they're going to have frequency, they're going to be at risk for leakage. All patients with fecal reservoirs have the potential for pouchitis. We'll come back to that. You're going to focus all of your attention on patients who have a two-stage procedure. Looking big picture, after stage 1 is all of the issues relate to ileostomy management. That's what their focus is primarily. After stage 2, they're going to have issues with frequency, urgency, the potential for leakage, and the potential for pouchitis. Now, the next few slides, we're going to focus exclusively on the management issues for patients with a two-stage procedure. That's where I want you to focus your attention. That's where your questions will be on the exam. And when you come to Bridge Week, you'll have a post-op competency for a patient who is having a two-stage procedure. So stage 1, yes, you have the reservoir, yes, it's connected to the anal canal, but more importantly, you have that loop ileostomy, and all of the stool is coming out of the loop ileostomy. So that's your primary focus, is management of that high volume output loop ileostomy. We don't totally understand why, but these loop ileostomies are frequently difficult to pouch. A lot of times they tend to tip down so that they empty just above skin level. So many times we end up using convex pouching systems. We'll talk more about that when you're on site. So first of all, we work with the patient on establishing a secure pouching system and make sure that the patient knows how to change that pouch, how to protect the skin. That's a huge focus in management for these patients. And then we're going to talk about the very same things we talk about to any patient with an ileostomy. The potential for fluid electrolyte imbalance. But for this patient, they're going to be losing even more fluid because notice this ileostomy is up the line. It's more proximal than a standard end ileostomy. So the patient has to be particularly vigilant. Every time they empty the pouch, they've got to go to the kitchen and get a 12-ounce glass of replacement fluid and sip along on that so that by the time they go to empty again, that glass of replacement fluid is empty. They empty, wash their hands, go get another glass of replacement fluid. We have to spend time reviewing the signs and symptoms of early dehydration, dark urine, dry mouth, what to do about it. We have to tell them if you start getting a little bit confused, a little bit dizzy, a little bit nauseous, you've got to call your physician, go to the emergency room. Dehydration is a very real threat for these patients. They have to understand that. Of course, we're going to teach them the basic things about preventing food blockage. Avoid foods high in insoluble fiber for the first 6 weeks. Add them back one at a time in small amounts. Chew well. Notice how you do. Monitor how you do. So, focus number 1 is managing the ileostomy, preventing dehydration, and preventing food blockage. That's pretty much all consuming for the first 4 to 6 weeks. But once the patient stabilizes, their output decreases, their fluid balance is stable, they're clear on their diet, they're comfortable with ostomy management, now our focus shifts a little bit to preparation for takedown, preparation for ileostomy closure, getting them ready for the next step. One of the things I want them to start doing is sphincter exercises. Typically beginning about 4 to 6 weeks post-op, we tell them you've got to get your sphincters in prime shape. They should be Olympic style sphincters. So I want you to start doing 3 groups of sphincter exercises a day, each group involving 15 reps. Tighten as hard as you can, hold as long as you can, relax for 10 seconds. Tighten as hard as you can, hold as long as you can, relax for 10 seconds. Okay. Second thing I want them to do is keep an intake-output diary so that before we close the ileostomy, they know which foods cause increased output, which foods cause decreased output, which foods loosen their stool, which foods thicken their stool, which foods cause them a lot of gas. That's going to be invaluable to them once we close the ileostomy. So they should be keeping a record. Okay? Now, in some centers, once the reservoir is well healed, so like 8 to 12 weeks post-op, but prior to takedown, they will implement a program to start to stretch the reservoir and increase reservoir capacity. And it's a very simple program. So you talk to the surgeon about this, you get surgeon clearance, and it's the point in time when everything is well healed. But then you tell the patient, get a little fleet cinema, dump out the fleets enema solution. I'm going to give you a catheter. Okay, so I want you to thread the catheter up into the reservoir. So usually we use just a 14 or 16 French catheter. Thread the catheter up into the reservoir. Take your little fleet cinema container and fill it with lukewarm water. So it usually holds about 120 cc's. Okay, so now you put the cap back on. You attach the fleet cinema dispenser to the catheter. And you tell them, okay, now squeeze that lukewarm water in until you start to feel full. Notice how much it is and practice holding it. Practice deep breathing, contracting your sphincter muscles. See if you can hold it for 5 minutes. Next time, see if you can hold it for 10 minutes. See if you can hold it for 15 minutes. Once you can hold, say, 60 cc's for 15 minutes, try increasing the volume. So now let me see if I can hold 75 cc's. Now let me see if I can hold 90 cc's. Now let me see if I can work up to a little over 100 cc's. That's going to make a tremendous difference to that patient post-op. So if you do start working with these patients, sit down, talk to the surgeon about doing some pre-takedown maneuvers to stretch the reservoir, increase capacity. Think about what if it was you. At baseline, that reservoir is very low capacity, 50, 75 cc's, mostly around 50, 60. Think about the fact that the average patient with an ileostomy has 750 cc's of output a day, and that's not counting gas. So what if you have a 50 cc reservoir? That translates into 15 trips to the bathroom a day. If you increase capacity to 100 cc's, it goes down to about 8 trips a day. Big difference. And would you rather practice on lukewarm water, or would you rather practice on enzymatic stool? Most of us would rather practice on lukewarm water. So if you start dealing with these patients, think about implementing measures to stretch the reservoir prior to takedown. Now, what can go wrong? These are the early post-op complications. I don't want you to focus on this a lot. You can always get an anastomotic breakdown. One of the advantages of the two-stage procedure is that should you have an anastomotic breakdown, you have plenty of time for healing to occur because the stool is going out the ileostomy. However, should you have partial anastomotic breakdown, it's going to fill in with scar tissue, and that increases your risk for stricture formation. So could you have an anastomotic breakdown? Yes, but actually that's not so common. You could have a little cuff abscess, you could get a little infection in here, and then they would treat that with antibiotics and drainage. I'm not going to ask you that. The most common complication is stricture formation. So you think about the fact that you have anastomosis reservoir to the anal canal. So you've got a circular anastomosis that's going to heal by collagen formation. It's going to tighten up. And so you can get a ring of scar tissue right at the anal rectal junction. Scar tissue doesn't distend, doesn't dilate, doesn't stretch. And that stricture can create obstruction to the fecal drainage, can make it hard to empty the reservoir. So one of the things the surgeon's always checking when the patient goes back post-op is he's doing a digital exam or she's doing a digital exam to see, is that anastomosis nicely open and patent? Can I easily put my finger through? Does it open up? If I can put my finger through easily and it opens up, then the stool's going to pass through. But if I encounter a lot of resistance and there's a very tight ring around my finger, then I know there's going to be resistance to fecal elimination. In that case, they're going to do repetitive dilatations. Typically, they teach the patient to do dilatations. There's some metal dilators known as Hager uterine dilators. They're the same things they use to dilate the cervix. And so we can teach the patient to just do very gentle dilatations. I've had to teach patients this before. Lubricate the dilator, put it into the anal canal, very gentle circular motions till you get through the anal canal. Let it sit there for 5 to 10 minutes, okay? Gradually using larger sizes. All of this is at the discretion of the surgeon, so we never decide to do the dilatations. If I'm teaching a patient to do dilatations, it's because the surgeon decided that's what the patient needs and asked me to teach the patient. If the surgeon asks me to teach a patient how to do dilatations and I have any questions, I'm going to go right back to the surgeon to be sure I'm very clear about what it is I'm teaching. So all I want you to know at this point is when you connect that reservoir to the rectal cuff, there is the potential for excess scar tissue that creates a stricture. The surgeon typically will diagnose that because they do routine checkups, digital exam, and either the surgeon will teach the patient to do repetitive dilatations or might involve you. Okay, so let's go to stage 2. Stage 2, the ileostomy has been closed, so now everything is going through the reservoir. All output is being controlled by the sphincter mechanism. So what are the issues now? First of all, I've got to protect that perianal skin because this patient's fairly high risk for some leakage, and that stool's very enzymatic. So I've definitely got to do skin protection. A lot of us will start the patient on low-level skin protection even after stage 1, recognizing that they might leak some mucus, and so we'll start skin protection early on. But always after stage 2. We always send these patients home on skin protection. Okay, so we start with moisture barrier ointments. Typically we're using a dimethicone type product that penetrates the skin, leaves a protective film, but is non-greasy. Okay, I don't want it to be uncomfortable for the patient. I don't want them to feel like they go squish every time they take a step, but I want to leave a protective film on the skin. If they're leaking significant amounts of mucus, if they're leaking any stool, I want to tell them about perianal absorptive pads. There are some products they can get over the internet called ARD pads, anorectal dressings, that literally fold in half, are very soft and tuck into right between the buttocks, okay, into the natal cleft. If they can't get commercial products, tell them to get very soft paper towels and take a square and fold that square and tuck it between the buttocks. Our goal is to wick any leakage away at the point of origin so it does not get caught between the buttocks and cause breakdown. So dimethicone type protective film, absorptive pad between the buttocks, and then very gentle skincare. We don't want anything else to irritate the skin. So we usually tell them wear white cotton underwear, use unscented toilet paper, no aggressive wiping. Better to have disposable like baby wipes so that you can gently wipe and not cause any more trauma to the skin. Now, what can we do to reduce stool frequency? Reducing stool frequency is critical to the patient's quality of life. This is the most distressing aspect of having this procedure, is the fact that you have relatively high volume stool being controlled by the anal sphincters coming through what's initially a small size reservoir. If we're going to give this patient long-term satisfaction and quality of life, we have to thicken the stool and stretch the reservoir. Those are the two critical things. Thicken the stool so it's easier to retain and less likely to leak. Stretch the reservoir so you're not running to the bathroom all the time. So these are the things we can do. First of all, they go back to that little record they kept and they're like, oh yeah, when I eat cheese, my stool gets a lot thicker. When I eat pasta, my stool gets thicker, okay? When I eat Mexican, my stool gets much more liquid and I have a lot more gas. Okay, well, you're gonna avoid Mexican for right now. You're gonna focus more on cheese and pasta, that kind of thing. Bulking agents can be very helpful. And when we talk about bulking agents, we're talking about things like Metamucil, your psyllium products. We usually tell them take 2 teaspoons in a small amount of water, like 3 to 4 ounces of water, not 8 to 12 ounces of water. 2 to 3 teaspoons and 3 to 4 ounces of water 3 to 4 times a day to thicken the stool, okay, to bulk it up. Loperamide, Imodium, they can take up to 8 tablets or 16 milligrams a day. So we kind of titrate it up. We might start with 1 tablet 4 times a day, so 2 milligrams 4 times a day, 8, 12, 4, 8, okay? If we need to go up to 2 tablets 4 times a day, we can. That gives them a total of 16. Loperamide has 2 very beneficial effects. First of all, it slows peristalsis, so it reduces diarrhea. Secondly, it increases tone in the internal anal sphincter and reduces the risk of leakage. Finally, it's non-addictive, has very low side effects, so a perfect anti-diarrheal drug for these patients. So we look at diet, we put them on psyllium products, we work with loperamide. That's done for almost all patients in almost all centers. And then we go back to how can I reduce frequency? Okay, I've got to stretch your reservoir. So first of all, I'm going to thicken your stool. I'm going to look at your diet. I'm going to look at Metamucil. I'm going to look at loperamide to thicken the stool. Next, I want to stretch the reservoir. So I'm going to have you doing your sphincter exercises because that gives you more outlet control. And then I'm going to teach you to do something that's very difficult, and that is to consciously delay defecation because I want to stretch this reservoir. If your reservoir currently holds 75 cc's and every time it feels a little bit full, you run to the bathroom, you'll never stretch the reservoir. So you have to teach the patient to do something that is very counterintuitive. When they have that urge to go, hold on. Now, one thing that we sometimes tell them is, okay, we don't want you to be worried that you're going to have an incontinent episode. So when you have the urge to go to the bathroom. So you're there. But once you're in position on the toilet, do your sphincter exercises and alternate sphincter contraction with deep breathing. So contract and hold, and then relax and do deep breathing for 10 seconds. So a couple of deep breaths. Contract and hold, a couple of deep breaths. Set small goals. Can you hold for 1 minute after you get to the bathroom? Can you hold for 2? Can you hold for 5? Can you hold for 10? As they hold, you see what's happening? They're gradually stretching out the reservoir. The longer they can hold, the more stretch they're getting on the reservoir. As the reservoir increases in capacity, their stool frequency goes down. If I can stretch that reservoir from 50 or 60 cc's to 100, 120 cc's, I cut stool frequency in half. All of our quality of life studies indicate that if we can get stool frequency down to 7 stools a day or less, that's the cutoff for good quality of life scores versus poor quality of life scores. So we've got to work with the patient on thickening the stool, stretching the reservoir. These are the critical factors. Long term, our goal is 3 to 6 stools a day, and this is how we get there. Thicken the stool through diet and bulking agents and Imodium. Stretch the reservoir by strengthening the sphincter and using sphincter contraction and deep breathing to delay defecation. Dietary modifications, very individualized. It goes back to foods that cause this person to have higher volume output and foods that thicken the stool and reduce output. Soluble fiber is usually very helpful. Soluble fiber is like your bananas and rice and pasta and smooth creamy peanut butter and Metamucil. Insoluble fiber are your raw fruits and vegetables. They tend to increase motility. So most of our IPAA patients, J-pouch patients, limit insoluble fiber. But again, go back to what works for that patient. For gas-forming foods, they probably want to time them, especially at first when they might not be totally confident that they can control that gas. And meds, just like any ileostomy patient, avoid sustained release and enteric-coated. What are the potential complications? Well, we've talked about a lot of these as we've gone through. Nighttime leakage. This is more common early post-op. We'll talk more about that. Persistent and severe diarrhea. We'll summarize prevention. Perianal skin breakdown we've talked about. Anastomotic stricture causing frequency and urgency, and pouchitis. So we'll talk about each of those in a little more detail. Nighttime leakage is typically an early post-op complication. During surgery, they actually have to do work through the anal canal to do the anastomosis. So those sphincters get initially stretched, and it takes time for those sphincters to regain tone. One of the reasons it's so important to start people on sphincter exercises. When they take down the ileostomy and everything's going through the reservoir, if sphincter tone is not back to normal, then they can have some leakage at night, because when we're asleep, our voluntary muscles relax. And if we have liquid stool, it can seep through. So you want patients to be prepared for that. I'd much rather tell them, look, a lot of people right at first leak stool at night. I want you to be prepared for it. I want you to protect your skin. I want you to make sure that you have a protective pad between your buttocks. And then I want you to have another pad in your underwear and your pajamas. And I don't want you to get too freaked out if this happens, because this is normal and it's temporary. As you do your sphincter exercises, as you thicken the stool, as you stretch your reservoir, this is going to go away. But be prepared. Perianal skin breakdown. Well, we're going to try to prevent that. But what if I have a patient who already has perianal skin breakdown? Well, I'm going to go back to what are we doing to thicken the stool. That's going to help tremendously. Okay. But what am I going to do to treat the skin? Dimethicone, my invisible film, will not give me enough protection if I already have skin breakdown. In that situation, I'm going to need a zinc oxide-based preparation, if I can get this out. So instead of an invisible film, I want a visible coat that I know is creating a significant barrier to that liquid stool and is protecting that raw skin. I do not want my buttocks to rub against each other. Can you imagine how awful it would be to be walking if you had zinc oxide on each side of your buttocks and you'd be like trying to pull one leg apart, the other leg? And I'm trying to protect that skin, so I do my zinc oxide, and then what do? My absorptive pad between the buttocks. So I want them to apply the zinc oxide. Every time they go to the bathroom, I want them to just add a little bit of zinc oxide. I want them to use the wet wipes for cleansing so that they don't get trauma. So cleanse with wet wipes, reinforce the zinc oxide, put your absorptive pad. Once I get the skin healed, I'm going to tell them stop the zinc oxide, go back to your clear barrier, your dimethicone type barrier. This is probably the most frustrating and most common complaint, and that is persistent diarrhea. 5 months, 6 months post-op, I'm still going to the bathroom 10, 12, 15 times a day. This is driving me crazy. I can't keep going through this. You need to have a pathway for managing persistent diarrhea. So the first thing you want to do is you want to realize that diarrhea can be caused by a number of different things. Maybe it's caused by their diet. Maybe the problem is they have never stretched their reservoir. But it could be that they have a stricture or that they have pouchitis. So a very good place to begin is by ruling out stricture, ruling out pouchitis. And you're going to be working with the physician to do that. So you may or may not elect to do a gentle digital exam, depends on your setting and your level of preparation. It's actually very safe to do a digital exam at this point. They're very well healed, and if you encounter a lot of resistance, then you're going to refer them to the surgeon for further evaluation for possible stricture and for management. Because stricture creates a barrier to emptying. If I don't empty effectively, I'm going to have a lot more frequency and urgency. Pouchitis, because you've got inflammation, then you're going to have inability to store any significant amounts of stool because the reservoir is so inflamed. Most of the time, patients with pouchitis, though, have other complaints. They have cramping pain, they don't feel good in general, they just feel kind of flu-like. They might have low-grade fever that would tip you off. They might have some bleeding that would tip you off. Bottom line, if you have any reason to suspect stricture, do your digital, any reason to suspect pouchitis, work with the surgeon to rule those out or to get those treated. Then, sit down with the patient, look at their intake-output chart. Help them identify foods that are contributing to their stool frequency. If they haven't done one of those charts, get them to do one. It will give them a lot of insight. It will help them to modify appropriately. And then go right back to how do we make things better? We thicken the stool and we stretch the reservoir. So you go right back through all of that teaching. What do we do to thicken the stool? We look at diet, we look at bulking agents, and we look at Imodium. What do we do to stretch the reservoir? We do sphincter exercises and delay defecation. If we can't make it better, some patients elect to go back to an ileostomy. That's the last resort. Anastomotic stricture, we've already talked about the issues with stricture, the problems it causes. Patients typically complain of feeling as if they don't empty completely, feeling like they have to strain. You feel tightness on digital exam. They complain of increased frequency, and we've talked about treatment. Pouchitis, we talked about under the continent ileostomy, is exactly the same thing. You've got a fecal reservoir. The causes are the same thing, or the theories regarding cause are exactly the same thing. But the symptoms are a little bit different because you have a reservoir connected to the anal canal. So J-pouch patients, IPAA patients with pouchitis complain of cramping pain, urgency, frequency, bleeding, malaise. Okay. To diagnose pouchitis, they'll just scope them. They'll just do an endoscopy, and then they'll treat with antibiotics, anti-inflammatory agents, and probiotics. So let's put it all together. I've talked a lot about complications, so you might start thinking, why would anybody have this done? So I want to balance it. Yes, we need to tell the patient this is not a piece of cake. You have a serious condition. It's made you very ill. You're going to have surgery. It's major surgery. It's going to take a period of time to recover from the surgery and to get to a good outcome. So I want you to be prepared for that. I want you to psych yourself up for this, okay? If you can psych yourself up, then we can work through this. And what I want you to know is most patients have very good outcomes. So here's what we know. There's distinct advantages: no stoma, no pouch, no catheterization. There are some disadvantages: the potential for fecal urgency and frequency. For some people it's long-term, but for most people it is not. For most people these are short-term issues. Night leakage and incontinence, short-term for the vast majority of patients. Very few patients have those problems long-term. Pouchitis, yes, pouchitis is a potential complication. Again, starting patients on probiotics early so that we help prevent pouchitis before it ever gets started, and skin breakdown. But what do we know? Generally good patient satisfaction, particularly high scores in the areas of body image and sexuality because there's nothing visible. Generally good outcomes functionally, 4 to 6 stools a day with minimal or no leakage. Now this is an interesting statistic, so just to balance the scales, if you look at complication rates for patients with ileal pouch anal anastomosis, either persistent diarrhea or pouchitis or stricture, 53% of patients undergoing IPAA do have some complications, whereas only 16% of patients undergoing standard ileostomy report complications. No real significant difference in quality of life, 87% of your IPAA patients, 93% of your ileostomy patients say that their quality of life is always better post-op as compared to pre-op. So if we summarize it, most patients who undergo standard diversions report quality of life that's comparable to the general public. But many of them report concerns related to leakage, to odor, to noise, and to sexuality. And we'll come back to that because we're going to be talking about rehab concepts in some later classes. What about continent diversions? Do they significantly improve quality of life? That's why they were developed, with the intent of improving quality of life. Well, continent diversion patients do report higher levels of social and sexual quality of life as compared to standard diversion patients. So are there advantages? Yes. Interestingly, if patients have complications, no matter which type of diversion they have, if they have a lot of complications, problems with pouching for standard diversions, problems with pouchitis with continent diversions, then they're going to have lower quality of life than if they have no major problems. Also, if patients were involved in the decision as to which procedure they should have, they routinely report higher levels of satisfaction with their outcomes. So we should involve patients. We should tell them what their options are. We should answer their questions honestly and allow them to make the final decision if they're candidates for more than one option. So, quality of life is generally good. Issues do remain. For continent ileostomy, the issues are the probability of additional surgery and increased stress when having to empty, having to drain in a public restroom. For IPAA, long term, the biggest problem is pouchitis. Ongoing research so that we're in a better position to prevent pouchitis in our IPAA patients. And that's it. If you have any questions, give us a call. Thank you.